I'm going to now just briefly introduce the panelists who will be talking with me today on particularly emphasizing the questions on screening for alpha-1 antitrypsin deficiency. So three very engaged young folks who will be participating today. The first, Monica Goldklang, is from Columbia University in New York, and she's a very active investigator in alpha-1 as well as a practitioner. Secondly, we have Igor from UCLA, who's engaged not only in alpha-1 education, but also is an intensivist and an expert in liver disease and the liver component of alpha-1 antitrypsin. And lastly, Kyle Hogarth, who is a pulmonologist, critical care specialist from the University of Chicago, where he also is very well known for his interest in alpha-1 antitrypsin and his ability to educate healthcare practitioners on this subject. Monica, what criteria do you use within your practice to determine that someone is appropriate to screen for alpha-1 deficiency? How do you implement this in your practice? I'll start with you, Monica, and then we'll go to Igor, okay?
Yeah, so I'm very by the book. I screen everyone with a diagnosis of COPD, regardless of age of diagnosis, smoking exposure history, or their heritage. In addition, I screen everyone with asthma with incomplete bronchodilator reversibility. And I believe that that's actually where we find a lot of these patients who are a little bit sick, but not very sick with alpha-1. And in addition, I'm very blessed to have some wonderful colleagues within our hepatology clinic. And so every patient with cirrhosis, even if alcoholic cirrhosis, is also screened for alpha-1. And so we make a large number of diagnoses that way. Obviously, as well, paniculitis, which I seem to only diagnose paniculitis in my alpha patients. It's very rare that a diagnosis of paniculitis backs me into an alpha-1 diagnosis, just by nature of my practice.
That's really very interesting. Monica, as a background, mentioned the great expertise in alpha-1 at Columbia University. And I, as a young guy, did 2 months with Dr. Jerry Torino when he was at Columbia. And then, of course, your colleague Janine D'Armiento is the president of the Alpha-1 Foundation, and you had great liver people, as you mentioned. David Brenner was there, and many others. So that's really a terrific background that you shared, and the Mara Center for Alpha-1 that Dr. Torino had. Igor, how about you? How did it happen at UCLA with Dr. Taskin and all those giants out there? How was?
No, listen, this is a great question, and Monica really nicely covered this. I mean, maybe what I can say is just add or emphasize a couple of things. So yes, there are things such as COPD, emphysema, get screened, but really adult onset asthma, as Monica has mentioned, even some common things that in internal medicine we can see. Bronchiectasis per se also should be a reason to screen. And then as you go beyond any end stage, we have a large end-stage liver disease program, and we're a large liver transplant center. I see the most of patients who are evaluated for liver transplant, and I can tell you anecdotally, in the past, unclear etiology of liver failure was tested for alpha-1 antitrypsin. In addition, I would like to mention something that we occasionally also skip. My patients, their relatives get tested, their siblings, their parents, and then at the same time, partners of people who are actually severe deficient actually get tested to get a projection for possible families, etc. And then I also need to mention one more thing. There is very particular new type of testing that is happening beyond our effort. And it's like all these commercial genetic testing kits that are coming. And I'm sure all of us who deal with alpha-1 are flooded with these healthy young people who just ring on the door of our offices looking for explanation. What the hell is this? I just did it, tested, and I got a paper that says that I'm prone now to get lung and liver disease. So I think that independent of us, I think that with the availability of genetic testing, and as we're moving forward, this is going to become more and more topic to talk about.
Kyle, we've been leaving you off the hook here too much, so I got to put you back to work. Is that okay?
That's great. No problem.
Now we're going to take advantage of you. You are really known, and I know this from your work, a great communicator to the primary care. So knowing that most people with COPD are being cared for by a primary care provider,
Right.
what do you say to those healthcare providers about the importance and ease of screening to rule out alpha-1 antitrypsin deficiency? So start with you, because of your great experience.
Well, thank you. No, I appreciate that. Thanks for the compliment. So I think it's pretty straightforward here, and the reason I say that is, number one, primary care is set up to already draw blood. So if it's going to be tested for from a blood draw, you're going to be drawing an annual CBC or a comprehensive panel or thyroid scan or lipids, whatever. So adding on one more blood test is straightforward. If blood's not an option, and obviously there are now buccal swabs as well that are part of being able to be tested. So there's a plenty of resources available. But I think what it really comes down to is, when it comes to lung disease, I agree with you 100%. Majority of the COPD is being managed in primary care, as it should be. And as part of that management and part of that evaluation, it's doing also the workup for the disease and doing, again, that rule out. And this is probably why it matters even more, because nobody just suddenly has advanced end-stage lung disease and ends up in the 4 of our clinics, right? They got there over time. And so long before you're arriving to see me, gasping and on oxygen, et cetera, you were progressing. And you saw somebody who diagnosed your COPD 15 years ago. And if they had diagnosed your Alpha-1 15 years ago, a lot more could have been done about it. And I think that's, again, where this information comes in. The ultimate in primary care would be to make this diagnosis before something becomes a major problem. We know that's why we do screening for malignancies, find them at early stage. So let's find Alpha-1, or at least the lung disease from Alpha-1, at early stages. I think the other key thing, too, is there's a lot of drug development happening on the liver side. Right now, we don't have anything for the liver.
That's right. Yeah.
I'm fairly optimistic as to what's coming down the pipeline. So if we're going to be drawing liver function tests, and my 2 colleagues highlighted real clearly here that it's not just a pediatric disease. And so when you have those abnormal liver function tests, even in your alcohol user, right? Let's work it up. Excellent. So, I think if you're going to prescribe an inhaler, there's a reason, and there's obstructed disease, and finish the workup. And it's that easy. It really isn't a lot of work either, right? I mean, tacking on one more blood draw or a simple buccal swab. Oh, and by the way, we already have data that shows once you explain to someone their increased risk for lung disease related to their genetics, you're more likely to get them to quit smoking, which that is the ultimate primary care.
Absolutely. Right?